As far as I am aware, I think this is the first medical ground round that's been devoted to the discussion of ethical issues of a case rather than the clinical scientific issues. What we're going to do today is to present two cases, and I hope that the discussion that will take place will bear on the ethical issues rather than on the clinical details of the case. We haven't had to go far to find the cases. They're both cases that have currently been in the hospital and died. And the topic that we will be addressing is the process of death and dying in a modern-day hospital. I'd like to just put up a slide. I'd like to perhaps have some issues that you might look at as the cases are being presented. We'll be talking about a person rather than a patient, hopefully, and that person's autonomy and how that autonomy exists or does not exist in the hospital setting, the right of the patient to die and the process of dying, and also the right to dignity, which so often is threatened in modern medicine. This person then is in a system which, in some respects in modern medicine, is oriented, particularly in a large hospital, towards curing at times at the expense of caring. Patient comes in, or the person comes in under an authority, the hospital and the staff. This authority at the present time ordains that you cannot die without an order to die, that the process of dying is in fact preempted by this authority. There is the paternalistic influence of those who are making decisions on the staff, which really abut on the autonomy of the person. And this system imposes the rules that one might say is the modern conscience of the hospital, but at the same time, I think, does not create a moral system which all people feel free to follow. The first patient or person is a 70-year-old lady who was transferred to the Vancouver General Hospital from another hospital for the urgent management of aortic stenosis. There was no history or physical or any complete type of history of physical done on admission. There was a brief note which made reference mainly to the dimensions of the aortic valve and the hemodynamic consequences, and mentioned also that there was a background history of diabetes and glaucoma. If one looks at the previous hospital record, it was obvious that this lady did have some feelings about her health. She had diabetes for a number of years and failing vision because of glaucoma. She also had a past history of colitis and a pancytopenia secondary to drugs. And it was mentioned in the previous records that she resisted being investigated and because of her problems, including the cardiac problem, but because of increasing congestive failure, she was admitted to hospital and was in the system. She had surgery, she was admitted about 10 o'clock at night and had surgery the next morning. Her post-operative course and the rest of her life was a disaster. She required treatment for shock. She was hypoxic. She had electrolyte problems, was obviously in severe congestive failure with pleural effusions. Her post-operative course was complicated by infection, colitis, deterioration of her vision, renal failure, and poor diabetic control. There seemed to be a total organ failure following her surgery. If you go through the record of the case, most of the details in the record, which now is about 6 inches thick, really relate to the clinical aspects, the blood gases and those other technical aspects. But if one goes through whatever remarks are made relative to the lady, these are some of them that are listed in the chart. Our course originally was one of someone who really just could not communicate in any way at all. She was so desperately ill. And she had a number of consultants looking after her, renal, endocrine, neurological, and later psychiatry. Just in terms of some of her problems in the clinical way, her BUN went up to 218, creatinine 5.2. She varied between stupor and semi-stupor within these dates. She then improved slightly, and psychiatry was asked to see her. And these are some of the remarks that are made relative to her only ability, I think, to personify her wishes. That she obviously was resistant to all forms of intervention as far as one could gather. She was eventually moved from the surgical intensive care unit to the surgical ward, had a nasogastric tube put in. And if one goes through the nursing notes, you can see that any attempts to feed her by spoon or syringe caused her to spit out her food. And she was, but at no time was she capable of talking or expressing her wishes. And this is on these dates. Her surgery was March the 12th. On the ward, on April the 15th, she had a cardiorespiratory arrest, and she was resuscitated. Post-resuscitation, she was flaccid and unresponsive. A neurological assessment the next day revealed that she was in a vegetative state and that no aggressive treatment was recommended. The other consultants in the case were in agreement. When seen approximately 1 week later, she was in a persisting vegetative state. By this time, was decerebrate on the right side, decorticate on the left, evidence of severe bilateral brain damage with the recommendation that her care be purely for comfort and dignity. On May the 1st, her state continued, and it was thought that it was proper to discuss her code status with the responsible physician in charge of her care. The writing of code blue was refused, and the reason given was that the level of her care would deteriorate if that code order was written. She continued to exist, and on May the 15th, she was transferred to the care of a family practitioner and moved to one of the back wards of the hospital. A no-code blue was instituted right away. She continued to be in a vegetative state, and when I last saw her this time, she was totally unresponsive, unable to swallow, had a constant drip of nasogastric feeding, had a catheter, and was wearing diapers. The nurses could not remember any visitors having seen her during this period of time. She had a daughter who lived in Surrey or White Rock, and she saw her during the acute stage of her illness, but did not visit her later. Then on June the 22nd, she died. The points I'd just like to emphasize is that this lady probably had no autonomy in the system, that she was hardly recognized as a person after admission. There was no details of who she was, what her background was, and the only really assessment that was made on admission was relative to her hemodynamic status. She obviously was dying, and obviously I think her rights were preempted. Not only her right to die, but she died, I think, in a very undignified way. The system, I think, that she was in did not realize or take into account this aspects of her autonomy and her rights. And it's on these aspects that the discussion should be on today, not on the clinical features of the case. Now, the people that we have talking today, I'd like to introduce. On my immediate right is Bob Thompson, who is one of the chaplains in the Vancouver General Hospital. Next to him is Paul Russell, who is in the Department of Philosophy at UBC, has recently joined the faculty from Cambridge and taught the course in ethics last term at the university. And Martin Tweedale, you know, who's head of the ICU and will be presenting the second case. What we intend to do is have Paul, first of all, address the issues of the case, and Bob Thompson will also address them from his perspective, then open this case for discussion. And we have a panel this morning. And then Martin will present the second case, and hopefully we'll have further time for discussion. Paul, would you like to?
Thanks. Great. What I'd like to do actually is really just elaborate on some of the points that Dr. Sweeney's been making. I think the best way to do this is to raise three issues concerning the treatment of the first patient, the patient that has just been described. Let me just sort of summarize these under the following questions. The first is, how is our understanding of the nature of a person relevant to the treatment of the patient? The second is, to what extent does a doctor have the authority or the right to prevent the patient dying? In other words, does a patient have a right to die as well as a right to live? And thirdly, what's the appropriate justification for refusing to intervene to save life? Now, roughly, I hope this diagram, this high-tech philosophy diagram that I've got here will give you the anatomy of what I'm going to say. So, I'll turn to the first question. What I want to discuss is really basically the relationship between persons, death, and respect. And just elaborate the point which was made in the introduction. That is that clearly a patient is more than a body which requires to be treatment and to be kept alive. A patient is a person to be cared for and respected. Now, I guess in modern medicine it's kind of trite to say that with all the complex technology that we've got, treatment by specialists, there's a clear danger of the patient becoming dehumanized in the system. Now, I think that the best way to avoid these dangers is to give due weight to the source of our respect for the person. Now, what I want to say is there are really two aspects to this that are particularly important in understanding this. First, we value the life of a person in virtue of the fact that they have qualities or capacities necessary for living a worthwhile life. Okay? A person, unlike a merely living body, has a capacity to pursue projects, interests, and enjoy personal relations. Okay, now secondly, a person also has the capacity to make decisions and choices. Clearly, depending on the individual, there are degrees to which a person has this capacity. But a person must have this capacity in some form or to some extent. This is the capacity of a rational, self-conscious agent. And such an agent has a capacity for what I'll describe as autonomy. Now, to respect the person is to respect that person, his or her autonomy. person has a right, on this view of respecting the person, to make decisions affecting him or herself, even if other people don't agree. They have to respect those decisions. Okay, now, kind of given this kind of very quick account of what a person is in this relation, in this context, I just want to say it seems clear that there may be circumstances in which the body is surviving. And I'll leave the technical aspects, the heartbeat or the brain waves or whatever. There's some evidence of the body surviving, living, but the person is gone and cannot be recovered. Now that means that in some sense it seems to me reasonable to say that the person has died, however much the body may be in this fairly rudimentary form still surviving or living. Okay, so let me turn now just to the second issue. I'll just try and structure this quickly. This is what I'll describe as the problem of paternalism and the patient's right to die. I'll try and show how all of these are really interconnected as issues, and it should be clear they're all relevant to one another. Paternalism is the policy of interfering with a person for that person's own interest or well-being. And insofar as this involves disregarding the person's own decisions or choices, it involves violating his or her autonomy. So if you want, there's a conflict here between paternalistic policy or attitude and respect for the person in regards to their autonomy. Now, I think it's clear, and I suppose you'll all be quite aware, that this problem is most acute when a patient decides that his or her life is no longer worth living, and therefore he or she declines or refuses life-saving treatment. Now, I think there are basically two kinds of responses to this situation which I want to distinguish. They seem close, but I think in fact very different attitudes and values are involved in them. The first is what I'll call the strong paternalist response, and the second is what I'll call the weak paternalist response. The strong paternalist takes the view that the doctor has the authority or the right to insist on such treatment for the patient's own good. We simply do what's best for the patient irrespective of their wishes or choices. Now, I think it's fairly clear that this involves a severe violation of respect for the person. And clearly it seems that our right to die in the manner and at the point that we deem appropriate, speaking of patient point of view, may be of enormous importance to the patient. And taking on that strong paternalist attitude or policy at that point seems a violation of that respect for that patient's decision. But there may be worries about this, and the weak paternalist response may be a more adequate kind of middle line between radicals or strong paternalism and a kind of radical autonomy for the patient. The weak paternalist takes the view that the doctor has the authority or the right to insist on such treatment if he believes that the patient's autonomy is impaired. Now, for example, I'm thinking there of the patient's decisions and choices are somehow deemed to be irrational or incoherent due to distress or trauma or mental illness. So the important point there is that it's the autonomy that's impaired, not the questioning of that individual person's decisions or values or whatever. If the patient's autonomy, on this view, if the patient's autonomy is not impaired, then his decisions and choices regarding his treatment must be respected. It's the weak paternalist point of view. So in other words, weak paternalism respects patient autonomy, whereas strong paternalism doesn't. Now, as in this case, the problem is, what if the patient's unconscious and not able to express choices or decisions himself? Now, I think if the patient's unconscious, then you can, as it were, indirectly respect his or her autonomy. And you can do that by referring or making some effort to refer to the family, to the friends, the GP, or finding out something about the patient's background so that you can gauge what that person's preferences would be in those circumstances. And I think finally, when a patient's personal qualities are irrecoverably lost, we have to consider at that point their right to die in these circumstances as well as their right to life. If we lose sight of that, we're going to lose sight of respect for that person and respect for their autonomy and their preferences in these kinds of circumstances. Okay, finally, let me just touch on this last issue, which I call the rationale for intervention. When considering when we ought not to intervene, I think this is the problem in this situation, when we ought not to intervene to save life, I think the best approach is to ask why we do intervene in certain circumstances. And again, I think there are two major considerations here. This is a philosopher's, two important points here. The first is I think that we're seeking to secure the patient's well-being by maintaining life or maintaining bodily health. It's one important source or justification for medical intervention, clearly. Secondly, we may seek to minimize their distress and pain. And there will be circumstances, and I think the second case we're going to discuss will show that in fact these two may pull against one another. There may be circumstances where in trying, say with heavy doses of morphine or whatever, you're trying to reduce or minimize the patient's distress and suffering, although clearly you may recognize that this is going to threaten the patient's life, but there may be reasons for not being too concerned about that. Now, given these two basic sources for justification of medical intervention, it seems clear that there may be some circumstances in which this rationale simply doesn't apply. And such a case would be a case where a person is irrecoverably lost. And it seems to me that in these circumstances, we simply have no reason to intervene. Where we have no reason to intervene of this sort, then it seems to me the patient should be allowed to die. And I think there are other indirect reasons for this as well, more straightforward. So prolonged treatment in these circumstances may violate the dignity of the patient, the way that we treat even a patient's body after death with some respect. It could cause distress to the patient's family or to the medical staff. And finally, it's clearly going to be very costly to the health service itself. So in these circumstances, not only do we lack a positive rationale, but we may well have good reason for not doing so. Okay, those are just the sort of general points that I just want to raise for a discussion of the case. Maybe I could just ask some questions about the treatment in terms of this for the particular case. The first is, given that on April 16th, that was just after the patient had the cardiac arrest, the patient was in a vegetative state, quote unquote, and continuing to decline, I think we have to ask ourselves is, at that point, had the person died on April 15th? Secondly, was due respect given to the person's autonomy by the decision to revive her on April 15th and by the order for aggressive management on April 18th? Were these instances of unacceptable paternalism involving denying the patient's right to die? And finally, just on the last issue here, the third point, how adequate was the rationale for prolonging the patient's life? And did this treatment really secure the patient's well-being? So I think this will cover it for now.
Thank you.
I haven't a printout for you this morning, but I'd like to just raise some issues and points that I've thought of as I've reflected on this particular case. In the first place, we should ask, who is this person? And it sounds very familiar, doesn't it? That I should be facing the same thing. What is her philosophy of life? Who are her significant others? Those needing consult for her continued care. Once cardiac surgery was imminent, was she consulted about what she wanted done if severe complications developed? And there's where I I'm raising the issue of keeping the person's sense of autonomy there clearly. Almost sounds like Paul and I were cohorts in preparing here. We did raise our issues and then did go at it separately. We need to keep in mind that a person is body, mind, and spirit. Each has a profound interplay on the other part of us. And I'm particularly reminded of an illustration from Reverend Colin Johnston, the chaplain over at the Cancer Control Agency. He shared an example or an illustration of a 75-year-old Mennonite woman who had cancer developed to a serious level, and she was given the choice of 6 months to live without any treatment or some very heavy active treatment with chemotherapy, which would go over a course of about 6 months, and the possibility of 6 months living after this course of treatment was finished. So in her dilemma of choice, she had some talking with her family and then had a time of consult with the chaplain, who happened to be Colin. And over that period of time, she looked at the pros and the cons of what quality of life would be for her, and she made the decision that she would refuse treatment and have the 6 months of living back home with her family, back home in the Abbotsford area with the solid support of her church and what quality of life really meant to her. There's a time to be born and a time to die. And this particular person raises the issue of allowing a person to die and caring for them through that process. And I label it as a process because we don't usually just like that out. There is a process of trimming the sails, so to speak, in sailing language. There is a process of getting your affairs in order. There's a process of saying goodbye to family, close friends, and there's a process of doing whatever we need to do before we're going to go through that journey that only one of us can go through that experience ourselves. Many times the terms used to describe death are couched in fear and in mystery. We use the term expired. What does that mean? Slipped away? Interesting. Prognosis is very guarded. And passed away. I've used that one myself. More and more I'm saying a person is dying. Because that is the process, that is their experience and what they're going through. Persons facing their own death need straight communication of something like, you're about to die in the near future. Have you any desires or have you any things that you want to do? In order for them to order their affairs, to come to terms with unfinished business and to make peace with their Creator. Families, though dulled by the shock of facing the near coming of a loss of a loved one through death, they need to be given the opportunity to say their goodbyes and expressions of appreciation for the person in their life, what they've meant to them. This is a gift of time for families, and sometimes this gift is very, very shortened because of a massive dose of heavy drugs which will control pain but also mask sharp thinking and being able to express what their real thoughts and their real feelings are. So I know there's a thin balance of that, providing some care and keeping the level of pain down, but giving some clarity of thought and helping the person to be as much in control as he or she can be. The order for a no code or a blue code is an awesome responsibility for an individual physician to take on. But is there some opportunity for this decision to be shared with the family, with the other physicians, with the person concerned, and with other professionals, and even perhaps the family's personal clergyman or chaplain in the hospital? I'm raising this. Is there a qualitative and quantitative difference between nursing care in a curing ward over against the care in a palliative ward? Perhaps there are different emphases in these two locations, but I sense both sets of nurses would proudly wear the button, "We care," in both those areas. I have experience being called to respond to pastoral needs in both the palliative care wards and in the very heavy intensive care unit wards. And I found there staff who were very caring. They had the person in heart, in their minds, uppermost. If an attending physician is worried about the effects on nursing care, his or her writing a no-code order for a patient might have, I would suggest, been raised with the head nurse, that these were some worries that he or she was having. Perhaps it might be more just or helpful if no-code orders were raised with other staff and family before a weekend replacement person might be in charge and have to make a practical and pragmatic decision to resuscitate or not. Another question this case raises is how much our interpretation of nonverbal behavior is affected by our own main goal in life. The person is observed attempting to gag herself, and this is seen by her finger being put down her throat, and it's interpreted as an attempt to die, to bring on her own death. But could it be that she was very humiliated to be kept on a respirator or be totally dependent upon other persons? And as I heard some more of the background of the particular person's condition, it seems that there was a resistance for a lot of intervention. On April 12th and 13th, there was no response to stimuli or pain. In a diabetic condition, why was the patient placed back on the respirator after cardiorespiratory arrest on April 15th? The question of having a respirator available for another patient requiring this treatment comes up. Can we as a society continue to afford to have a respirator tied up with a person whose future indication for full life is non-existent? On the other hand, who is to judge what is full life for an individual? And I'm very aware that both sides are there. I'm recalling a person who had a bad stroke, no speech recovery, and yet that person, through sensitive touch and meaningful glances and warm friendship, touched a lot of other people and had a full life. So it's necessary to involve the family or significant others in the making of a no-code decision with caution that if there is a lot of money involved in a possible inheritance, that has to be weighed as well. There are more areas to explore, but I conclude with what I've presented for us now.
Unfortunately, there's apparently been a major fire in one of the hotels in town, and Dr. Tweedale has been called to the intensive care unit. This means that we will not present the second case. We therefore have plenty of time for comments and discussion about the first case. And I'd like you to address the comments to Paul or Bob, more than to myself, insofar as the issues are hopefully being kept to ethical issues. Dr. Price.
Thank you, Dr. Sweeney. I think this was a very instructive case, and I think all of us will agree that in many ways was not well handled. However, as someone by nature of the work that I do has had to make these decisions on many occasions, I think there are aspects which have been left out, and it's very easy when you don't have to make the decision yourself to philosophize about these sort of decisions. And it's when the buck stops here that it becomes very difficult to decide. Now, whose values are going to be used to decide that this person's life isn't worth living? Is it my values, or your values, or the patient's values, or the relative's values, or who? We all know that when patients have an acute illness, they may become depressed and say life isn't worth living. Now, is one to take that statement as the decision that this person should be allowed to die? And I'd be very interested to hear what the panel feel about these sort of decisions, because this is a type of decision that is becoming more and more important, and many hospitals now throughout the world have set up ethics committees to assist physicians in making these decisions. And these ethics committees, some of them are executive in that they decide whether a patient should live or die, and I somewhat question that. And others are just advisory. And I'd like to hear what the panel feels about this.
Paul, would you like to?
Yes, absolutely. Well, I'd like to start off by saying that I do feel a certain embarrassment, coming in with no responsibilities, and as it were, seeming to pontificate, which is not my intention at all. At most, my intention here is simply to try and raise questions which you, on the front end of it, and the extremely difficult and far more complex end than this could suggest, have to think about at least, and maybe to stimulate your own reflections on it. So I entirely take that point.
You're talking to the microphone.
Yeah, sorry. But to just one point I would like to make in light of what you said is that yes, this is an appalling responsibility to have to say, well, do we have somebody who is irrecoverably, is the patient irrecoverably lost here as a person? What constitutes the person being gone and irrecoverably lost? And the points that Bob was making at the end about even someone who can be very badly damaged can still have family coming in and get some benefit from the personal relations. All of this means that I think if anything was to be done, I would think that one would want to err on the side of caution, to say the least. But that said, one of the things I was trying to sort of tease out of this just reflection on this case is that the difficulty here is that some kind of decision is going to have to be made anyway. And the thing that can be lost sight of is that as long as we're erring on the side of caution and trying to keep the patient alive, it may be thought that there can be no cost for this policy. But there may be a very bad cost. That's the thing to be kept in mind, that the difficulty of the decision is inescapable no matter which side you come down on it. Because if you make the decision to prolong life, as it were bodily life anyway, when someone gets into this condition like this lady was after her cardiac arrest, it may be that this is a violation of the person's right to die as much as one would have concern about a right to life. Now, I totally accept the gist of your point is that we must, I suppose, give emphasis to right to life, not least because the situation is irreversible. And I would totally sympathize with that. But I think at the same time, with that concern, it can be lost sight of that there are issues to be addressed on the other side of it as well. And these have serious ramifications which can be lost sight of. And one kind of moral response to the situation, I think, is just to sort of opt out and say, just keep everybody going. We won't do anything because there's no cost in this as a kind of fail-safe policy. But I think there's just reason to doubt that. But none of that makes it any easier from your end. Makes it very easy for me.
Bob?
Appreciate very much your discussion and sharing, Dr. Price. I've not been involved in making a decision like that, and that's why I realized the heavy weight of importance and pressure that must be on a person to make that decision. I would look at a ethics committee not as a executive to make the decision for persons, but as a backup or an referral place where a person could get some reflections from a group of people who have done some thinking about similar cases, and that then there still is the individual decision to be made by the attending physician. That would be my thoughts on how to handle a issue like this.
Just 2 points. One is that there now is an ethics committee being started in the hospital, which hopefully will not be executive, but hopefully will be advisory. And we're hoping that we will not need to be advisory until we've had some time to practice and think about things for several months to come. But at least it's the beginning. The other point I'd just like to make in the context of Dr. Price's remarks is the need for those of us who are taking care of patients to be as familiar with the person as with the disease, because we are thrown in that position of responsibility. And if you do not have the knowledge of the person as much as you do of the disease, then you can't make the decision, or you can't participate fully in the decision. And I think that this case illustrates that very well. Dr. Anderson.
Just a couple of things. I guess I would like to emphasize the last point that you made, Vince, that one of the problems with acute care modern medicine is not so much the technology, it's the fact that the person may be transferred here as a tertiary first referral hospital. You've lost the family doctor who's perhaps looked after the patient for many, many years. The family may be out of town or whatever. And with the multitudinous numbers of interns, residents, and specialties seeing the patient, there's no one person who really is close to the patient who makes the appropriate decision. And somehow one has to get around that system. One person acts in that capacity. Secondly, I think we are perhaps overlapping two issues. One is a decision as to when this patient really is dying and in an irreversible medical state. And secondly, how we deal with the process of dying as physicians. And we've talked about that at Brown's previously. And the more uncomfortable you are about your own death, the more uncomfortable you are about dealing with death in your patients. And the more uncomfortable you are, the more you either back away or the more heroic you become to try and save that patient's life. That's another topic of discussion, I guess, but it obviously influences very greatly how we treat the patients.
Yes.
I want to comment that you skirted at the beginning, I think needs to make the patient's perception of all of this through the whole illness is so important. And I think that I've been impressed in this hospital in our dealings with this neurology sometimes. The nurses in their increased training are getting quite good at communicating with patients and families often about as they get terrified by the new technology and what's going on. I think sometimes physicians in their trainings are not given this encouragement to communicate through this technology, or they communicate with the nurses, and I think it's an area. And the very comment at the very beginning, this lady there wasn't the physicians who were looking after her here didn't know a huge amount about it, and that scenario we have to.
Paul, I'd just like to, or Bob, address what's maybe been brought up by the remark of values that and getting back again to paternalism and autonomy, the question that Dr. Anderson brought up was one's perception as a physician or as a nurse of death and dying, and those values that you have in relationship to the person that you are ordaining for.
Well, there are certainly two. The difficulties, I guess, can run in two directions here. You, as a physician, I suppose, could take the view that somebody still has potential for a worthwhile life, whether through some kind of personal relations, interests, projects, whatever. But the patient, and I suppose you might face this with people who are paraplegics, may take a different view. And that means that you've got to, as it were, decide whether or not that person is in a position to make a reasonable decision, especially if the patient, say, recently suffered the injury and is, traumatized or distressed by it. And it seems to me, along this line of weak paternalism, that you might well say that it's not that you don't respect the person and the person's autonomy, but you think that the person really is not in a position to make the appropriate decision at that point. Even judging that is something that's extremely difficult, obviously, but something which may need to be done and need to be, exercise great caution on it. I guess in the other direction, the problem may be where you've got a patient who you really believe doesn't have much of a future, their personal qualities and capacities are really declining very rapidly, and they're in great distress, and so on and so forth. And they, nevertheless, have a great will or wish for you to actively intervene on their behalf. Now, it seems to me in that case, there's no problem for the physician. It seems that you should exercise your capacity to act on that patient's behalf and to preserve life, even though you may take the view that the person is possibly better off without intervention. But in that case, it seems to me there's less of a dilemma than in the case where the patient seems to be losing the will to live. I don't know if that's what you wanted to get at, but
Yes.
As what I like to think as an idealistic young physician, I've often thought how useful the idea of talking to the patient early in their admission about their attitude towards how they'd like to be managed if they decline. I think it's something I've always been interested in. But it seems awkward if a patient comes in and appears reasonably well to approach this question. But when you see a chronically ill elderly person who appears to be in a decline, then that probably is the right time to do it. You have to balance this against the idea of the Aesculapian authority that physicians have all been invested with. But how do we balance our judgment, our inner judgment about how this person should be managed versus inviting the patient's opinion on how they'd like to be managed, and then having to deal with the complexities of them not understanding their medical condition as well as we do, although understanding their inner feelings much better than we do. So I wondered if anybody had any thoughts about how to approach the question of asking the patient, probably early in their admission, about how they'd like to be managed.
Bob, do you want to?
I've had a little experience with visiting with persons over this past 6 years, and some of the persons facing surgery are well prepared for what they're going to go through. I am impressed with the amount of time and the amount of caring that has been given to preparing persons before surgery. I've just been amazed. There's been a few cases where I've visited with these people and discovered that they're scared spitless about what's coming because they haven't had the time with their surgeon to really talk about what they value and what they're worried about, to just get it out here and then realize once it's out here that it doesn't have near the fear that it had when it's inside and doing a job of festering. And so part of my work has been to listen to them, to raise with them the questions that they are raising, to suggest to them that maybe they need to raise that question with their physician if that's what's worrying them. I don't plan to be any kind of an authority on medical expertise because that's not my field, but I do listen to the worries and the cares and the the values that the person has. And so I think that probably is a proper area to really get into what values the person is holding. And yes, it would be premature to talk with a person coming in for an exploratory a biopsy to say now to them, well, what do you want me to do if you have a turn for the worse? That is premature. But somewhere along the line, once the diagnosis is done and the prognosis is really prepared, then is I would think, a good time to talk with a person about if there should be a time in the future of where it's looking like you're going to be going through the process of dying. What do you want done as medical practice? And that way I think we could gain a lot of help from the patient and their values as well. I don't know if I've answered your question as thoroughly as you'd like.
I just wonder if anybody in the audience has a
Yeah,
comment
that's...
Yes.
I think the idea of talking about one's right to die, I would wonder what kind of responses we get from, say, 100 people in the street, whether or not they actually thought about that they have a right to die, or when they have even looked at that in terms of their life. So when you come to crisis, this is a time when you have to come to terms with this every person is very bad. So we can talk from a philosophical point of view and also from the point of view of having had to counsel patients who have major changes from my perspective of knowledge position. But I've had to adapt, you have to adapt to all kinds of changes. But I think the idea of how, whether this should be something that should be started in the school system, where we look at death as being, part of what we have to look forward to, or how do we deal with it and what our rights are. But I think it's to take back wisdom and take on perspective in light of the situation as present, where at the moment the patient isn't likely to hand over that responsibility. They don't want to take charge of it. It's not something they have to act seriously about. Why do we feel that that's a problem?
Yes, I think that's part of the other side of the coin in terms of modern behavior is that 50 years ago, grandfather and grandmother died at home, and you were familiar with death, and that familiarity with dying is gone. Dying takes place to a large extent in institutions, so that the generations that are coming up now do not perceive death as something that's personal, even though every day they live is nearer to death. And the inevitability of death is built in, should be built into our philosophy and our psychology as well as our biology. But it's been taken away, at least in Western society, by the fact that death is not part of the household or the home. And I think this is one of the reasons why it's not addressed. Two questions, one at the back there, and one Dr. Grove.
Thanks. Thank goodness very little is being mentioned today about the costs of maintaining people's lives, but occasionally one does hear this, and that's deeply bothersome. Our society becomes so economically and politically and morally destitute that we have to worry about dollars and making life and death decisions.
Well, the answer to that question is yes. If you go to the hospital and go to the special care nursery, you see children that cost $1 million when they're 9 months old, and you think we've reached that point. And I think we're facing the problem even further with the epidemic of AIDS patients coming up. And I think we have discussed with these patients beforehand what they want to have done, what the society is willing and capable of doing.
So could I just sort of elaborate on that as well, which is that I think there's a totally reasonable point that it's a very sad day when society isn't willing to channel a lot of resources into medical care for sick and dying people. And I'm sure everybody would, well, every civilized and humane person would sympathize with that. But I guess there really is a genuine problem that it's not a kind of unlimited amount. And depending on the sort of care and the circumstances that could be put forward, this really may make people feel that it's not a question of being unwilling to provide funds at all, which is a totally reasonable point. But there may be real concern about priority and claims given a limited amount that can be supplied. And in this context, it does seem to me, when we are dealing with people who really are beyond recovery, that there must be, at some stage, that must be a legitimate concern if we are dealing with huge amounts of social cost, which may actually mean a loss to services in other directions for people who could benefit from it. I want to make that point, at the same time recognize the thing that we wouldn't want that to slip into some kind of dehumanized kind of concern about how many bucks we're spending every day.
We're nearing the end. I would like to invite two comments. If there was someone from nursing who would like to make a comment from a nursing perspective, and also maybe Dr. Meek might want to make a comment in terms of his perspective.
I think one of the points made was timing is everything. And I think I can identify being from a long-term chronic care type of environment for many years now, that I agree that decisions must be devastating for physicians to have to make with family. I think it's a team approach. I think nursing has to be involved from the date of admission to the date of death, and that timing is everything. And in a couple of cases, the time had passed when it was time to discuss with that patient, and that patient was no longer able to make those decisions or able to discuss them in a rational manner. And therefore, they lost their autonomy and their right to make decisions because we waited too long to discuss it with them. So I'm hoping that we take a team approach to the ethical concerns, and that we pick our times and we keep it in mind at all times, and try and prevent a lot of the dilemmas that have occurred with this particular case.
Well, I think this is the kind of issue that any doctor or any nurse can speak about for some time, but I was pleased that I guess it was one of the residents talked about the costs, because I recently read a quote from Dal Brower, who the old BC people know used to be the president of BC Electric. He said, if you're not a socialist when you're younger than 25, you have no heart, and if you're a socialist after you're 25, you have no mind. And I think we ought to teach young doctors and young nurses to look after patients and do their best and be ethical, but not to be quite so concerned about costs as those of us who are well over 25 are. But there is no question that our society will not tolerate 98.9% of our gross provincial product being spent on health care. And I won't tolerate it as a taxpayer, and neither will anybody else in this building. So there is a limit to what you can spend, and we do have to look at both sides. One thing I thought here is that, from my perspective as a physician, we're skirting around the issue, because I don't have any problem with what you're talking about, which is the middle-class patient with cancer and a family doctor and all that kind of stuff. The problem that I have, and many of the medical people have, is the alcoholic who lives in an East End hotel who doesn't have any family, who thinks dignity is the guy who lives down the hall that he drinks with, who never has heard of autonomy, and who gets run over by a car, and who takes a chance on his life every day. He comes in here with liver failure, he comes in here with multiple injuries. That's the kind of person that I have a lot more trouble making the decision about than the guy who lives down, in an apartment and has a wife and children and all that sort of thing. That's an easier decision.
But aren't we then sort of confusing capacity with the realization of the capacity for a worthwhile life? The question really hasn't been, whether this person has a worthwhile life, or at least in our middle class values, our Western values, but really in whether he has the capacity to form those sorts of relationships. Surely, in that sense, the Skid Row person is just as capable as your average middle class citizen. I mean, in reality, perhaps he hasn't realized it, but is that really... he has a choice.
I think I perhaps should intervene. That's obviously a discussion that could go on and perhaps should go on in the corridor afterwards. This whole subject is obviously one that could take up a great deal more time, and we will have further sessions of this type. Before thanking the speakers, I'd just like to mention next week's grand rounds, which are on the subject of osteoporosis, some current controversies, which will be given by Dr. Bert Cameron and myself. I'm sure we would all like to thank particularly Dr. Sweeney for putting together, if that's the right word, this interesting discussion. I'd like particularly to thank Paul Russell and the Reverend Thompson for their thoughtful contributions. And I'd like to invite them to come back again for another session as soon as possible. Thank you very much.